Anyhow, to discuss meniscus repairs, these are my disclosures. Why repair? As previously stated, partial meniscectomies worsen over time. There's an increase in radiographic symptoms of up to 90% at 14.5 years, and 67% of these patients will have symptoms. Repairs are effective and technically feasible. Number of clinical decision-making factors, as we've discussed: symptoms, age of the tear, the location, the morphology of the tear, tissue quality, knee instability, and occupation and timing of sport. So one of the key things that many of us think about in terms of sports medicine is when we want to repair or consider meniscectomy in the athlete. There's been a few recent papers on this specific issue from very well-respected international experts. Both meniscectomy and repair have a very high rate of return to sport of about 85%, but the revision rate is significantly higher with repair. And lateral repairs actually function fairly well. The lateral meniscus heals well, and so they recommend repairing this even in athletes, since a meniscectomy on the lateral sides has a significant risk of chondrolysis. However, on the medial side, medial meniscectomies do seem to have a better return to support and a decreased reoperation rate, although there are still the long-term concerns about increased osteoarthritis. We've previously mentioned the vascular zones, the red, 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 white, and white, white zones. This may play a role in healing. However, there have been more recent papers showing a higher success rate in avascular repairs. A number of outcome factors have been described: rim width, ACL intact, the tear length, chronicity. Age does not seem to be a significant factor, and whether or not the tear is degenerative versus acute. We have a recent paper in the Kesta journal with mean 4.3-year follow-up on repair in patients over the age of 45. 89% had clinical success, but on imaging, 41% still were unhealed. Other reviews, systematic reviews of repair outcomes at greater than 5 years, found an overall failure rate to still around 20%. The medial side fails more often than the lateral side. Inside out and all inside repairs have roughly similar healing rates, unlike the early generation of all inside repairs, which were rigid fixators. I think nobody's really using those at this point. ACL reconstruction does seem to help improve ACL healing and repair. So how can we enhance our results and enhance our repair? Patient choice is obviously a critical aspect, and we can think about those factors as previously discussed. But some of the things that I'll talk about are more technical. You want to be able to recognize the tear. Ramp lesions and root tears are often missed. You want to improve visualization and access, as Peter was previously discussing and most of the other presenters have discussed. Pie crusting can improve that. Mechanical stability of the repair construct is very important. And I think one of the ways we can think about meniscus tears is that this is essentially like a fracture or a fracture non-union, because it is a tear, there is very poor vascularity, there is no healing in that area. So if you want to try to heal a fracture that has not healed and has no blood supply, you're going to use good fixation and you're going to try to get some biologic stimulation in that area. So again, repair tips, recognition is important. You want to recognize ramp lesions and you want to recognize root tears. The MRI ghost sign is an important factor in this. And you want to enhance your visualization. So we talked about pie crusting the MCL, which is taking an 18-gauge needle and doing multiple perforations. We have a paper that's been submitted recently, and what we've demonstrated, if you use systematic pie crusting, after about 12 punctures, you get about 1 millimeter of increased MCL elongation and opening on that medial side. Increasing that will increase your exposure. The other clinical question that has been asked is, does this MCL release or pie crusting cause a problem clinically? And the data suggests that this does not affect valgus laxity or clinical outcomes. And in fact, there are some papers suggesting that use of the pie crusting technique results in increased medial meniscus healing. Another technique, and I think Dr. Lee may go into this, that I've learned from doing meniscus transplants is particularly for root repairs, there may be some benefit for doing a reverse notchplasty or a spineplasty of the tibial spine in order to improve visualization and increase access for your instrumentation into the posterior aspect of the knee. You can see that in this area, Where the circles are is where we've done a bit of a removal of bone, and that does provide increased visualization and access for your instrumentation. Mechanically, you want to have good fixation of your meniscus tears. We've talked about open repairs, outside in, inside out, and suture-based fixators. All of these work, but they do have different strengths. And for me, the workhorse is still inside out suture-based techniques, because the size of the hole that you create in the suture configurations are often more flexible, and you can put in more sutures than you can with all-inside techniques. A number of suturing devices have been developed, and these are increasing in sophistication and can be used very successfully, and I think have an important role in trying to create increased mechanical stability across your repair. This is an example of a patient who is an 18-year-old basketball player, young patient, radial oblique tear, posterior horn body at the popliteus hiatus. So this is a difficult tear to repair just with a simple suturing technique. So in this case, again, using a combination of hay bale sutures and an all-inside suture device, a hybrid fixation technique does help allow you to anatomically reduce that and get some mechanical stability across those fragments. Again, also with meniscus root repairs, loop sutures like what we see here can help enhance the stability of those repairs. So what we know about mechanical stability of repairs, specifically for root repairs, suture placement is better if placed into the body of the meniscus rather than the root. You want to use 2 or more sutures because that's stronger than 1, and again, this makes sense from what we know from fracture and other soft tissue healing. And complex suture patterns are more stable mechanically than simple sutures. So using a loop, a locking loop, a Mason Allen, or a cinch stitch, all of these seem to have equivalent strength, but are definitely stronger than a simple stitch. Some things that do not seem to make a significant difference mechanically is whether or not you use an anchor or a transosseous tunnel clinically for the repair of a meniscus root. But both of these are clearly superior than suturing the meniscus root to the residual stump. Using 1 or 2 tunnels, again, does not seem to clinically make a difference according to Laprod's data. And then using tape versus suture fixation, there's these wonderful high-strength suture tapes available, but on cyclic loading, these seem to be relatively equivalent. And finally, the type of fixation that you use on the tibia does not seem to be important. Finally, we can talk about biologic enhancement. A number of people have already mentioned the use of rasping to stimulate the synovium and stimulate bleeding in the area. Again, we can think about this as almost like a fractured non-union site. You want to try to enhance the biology of a relatively avascular region. So in this case, I typically will use marrow venting using a marrow access device and additionally a fibrin clot or even a bone marrow aspirate clot. Bone marrow venting clearly seems to augment healing of the meniscus, first often demonstrated in a goat model with marrow venting, 65% complete healing, 87% had at least partial healing. Without the marrow venting, only 12% had complete healing and only 28% had partial healing. So microfracture or marrow venting significantly increased complete meniscal healing, at least if you're a goat. So what's more important? Let's talk about people and clinical outcomes in patients. So Laprod's article in American Journal of Sports Medicine looked at 109 patients, 37 with isolated meniscal repairs with marrow venting, and 72 that had meniscal repairs with a concomitant ACL reconstruction. There were no significant differences in any outcome, so augments with marrow venting are comparable to that with ACL reconstruction. The overall failure rate was 9.5%. The only association they found was in female patients had a higher failure rate. Another interesting study in the Arthroscopy Journal in 2019 out of Poland actually was unique in that it actually had second look arthroscopies. And so this was a study that involved nearly 25 patients in each group with second look scopes. The marrow venting group had 87% of the patients had complete healing, and the rest, the 13% residual, patients had at least partial healing of their meniscus tears. Without the marrow venting, there were 43% that had complete healing, 33% had partial healing, and 24% of the meniscus repairs failed. So I think this is actually one of the most interesting and strongest papers where we actually have second look information about healing. Platelet-rich plasma. This has been previously discussed, and Chris Kading's group at Ohio State looked at meniscus repair surgeries with and without PRP. There were not statistically significant differences overall, with a 14.7% failure rate in the plus PRP group and 17% in the minus PRP group. With the isolated repairs, though, there was about a 20% failure rate, which decreased with the use of PRP. With the ACL group, the use of additional PRP did not seem to make any difference. Nicola Mafuli also did a nice meta-analysis, and they found that IKDC and Lysholm scores did not significantly differ between the groups that had PRP or not. You can see the actual odds ratios around revision and failure. Again, statistically, these did not seem to have decreased revision or failure rates, but there seems to be possibly some trend towards that. But no conclusions could be made at this point in time. Another traditional way is to use fibrin clot, and Charles Henning described this almost 40 years ago. 50 to 75 milliliters of venous blood and a ground glass syringe can be used, stirring, and you can get the clot. This can be scraped off with a scalpel and then sutured and passed through cannula into the defect. So Chuck Henning in 1990 found that for isolated meniscal repairs, there was an 8% failure rate if you use the clot versus 41% failure rates if no clot was used. A more recent study out of India with a 2-year prospective study was published recently and found that in 35 patients, there was only 1 re-tear, and MRIs demonstrated complete healing. And I love the picture on the right of somebody clearly demonstrating that their meniscus appears to be clinically functioning. Finally, you can use bone marrow aspirate. There is a Japanese paper where they did take a bone marrow-derived fibrin clot, and you can see that what they did is actually they put the needle through the intercondylar notch into the end of the distal femur and aspirated that way in order to get the bone marrow. So this is something that can be done on the field, and they sutured this into this area. In the avascular zone plus the bone marrow clot, their clinical failure rate was only 10%. So my final recommendations are, at this point in time, if you have a lateral-sided tear in an athlete, you want to try to repair that. You want to repair root and radial tears. You may want to repair the medial side, but you want to be aware that there is a significantly higher failure rate, and in an athlete that you may be concerned that this may result in repeat surgery. Recommendations for enhancement are to always try to make sure you have good visualization and access. And so pie crusting the MCL can open up the joint, and also if you're working on meniscus root or ramp lesions, notchplasty or spineplasty can improve access for your instruments and visualization. You want to use mechanically strong fixation, and you want to use biologic enhancement. I always use marrow venting. I will often use a fibrin or bone marrow type clot. Thank you very much, and it is truly an honor to be here.